Thank you, Keith. Thank you, Richard. Respiratory Associates, thank you for having me here today. As Keith said, today's topic of conversation is all about driving pressure. Let me spotlight my video here. There we go. All about driving pressure. Now, the title of this is Driving Pressure Out with the Old, In with the New. And like he said, my name is Joe Lewis. You know, I remember the time that I was extremely confused back in, let's go back to around the year 2000, to the mid 2000s, all the way into the around 2015, 17, 18. There was this shift in mechanical ventilation that all started with the ARDSNet protocol. And we're going to take a look at that today. And we're going to kind of show how that kind of brings and brought a lot of this to light. And so I remember exactly where I was sitting, the seminar I was in and the lecture I was listening to, when my mind was opened up to this idea that we had transferred from. Remember, late in the 80s and 90s, even kind of into the 2000s, we were using very large tidal volumes. 10 mLs per kilo was not abnormal. A 70 kilogram man could easily be on a tidal volume of 800. And peaks were very, very low. And then there was this shift in mindset where it's like, wait, now we're going to raise the peaks, but we're going to drop the tidal volumes. We're going to go down to 6 or maybe even 8 mLs per kilogram. So it was a shift in mindset. And I never understood how this was going to lead to better outcomes, especially when you considered the fact that a lot of times, because you were given a smaller tidal volume on a higher peak, your peak inspiratory pressures and your plateau pressures were still about the same as what they were when we were using 10 mLs per kilograms. And so I was unable to figure out how this was beneficial. And it wasn't until it was illustrated in another driving pressure lecture for me back in around 2017 at a conference that I walked away thinking that is the most mind-opening concept in the field of respiratory therapy that I've ever seen. That's me personally. Now, I don't expect you to walk away with that, but I hope you do learn something. We're going to have some objectives here that we're going to focus on. We're going to define driving pressure. We're going to describe driving pressure's effect on mortality and pulmonary complications. And then we are also going to identify a couple of complications that you may run into when you are assessing driving pressure. So let's jump into this. Now, before we get started, I have a question for you. You see here on my board here, I have two patients, patient A and patient B. And the question is simple. When you look at these two patients, evaluating the data that you have, which of these patients is at a higher risk for mortality? That's the question. So you have patient A over here, who's set on a tidal volume of 6 mLs per kilogram. We've got a plateau pressure of 28. And we're on a PEEP of 8. Over here, we have patient B, again, 6 mLs per kilogram, no difference there. But we have a higher plateau pressure at 32, and we're on a PEEP of 20. Now, I want you to ask yourself, you don't have to put it, don't answer it yet, but I want you to ask yourself, do you recognize which of these patients is at a higher risk for mortality? We'll come back to this in just a little bit. First question we have to ask ourselves is, what is driving pressure? I think it is seriously one of the most challenging concepts to put a definition to when you're asking yourself, okay, I get it, but I don't really get it. What is it? And what we see here is a pressure waveform. And I think if we were to go in and label this, we could probably all label the pieces of a pressure waveform. We know that here we have PEEP. This is positive end expiratory pressure, and we know that that is the baseline for which alveoli are held open to during the expiratory phase. We rise up here and we see that this point right here is our peak inspiratory pressure. And we know that while the gas flow is moving through the airways and opening alveoli, this is the generation of peak inspiratory pressure. It is useful in helping us to calculate and to assess airway resistance and dynamic compliance. And we come down here and we see that we have our plateau pressure. Now, plateau pressure, we know, is when we do an inspiratory hold and we see where that volume settles into the alveoli during that inspiratory hold. This happens in the presence or the lack of inspiratory flow. So when there's no flow moving, just holding the breath in the lungs, where does the pressure fall to? And we know that is plateau pressure. We know it is very helpful in allowing us to assess static compliance. And then, of course, we return down here to PEEP. We already talked about that. We know that when we look and take an average of all of these pressures, we get mean airway pressure. So that's the average of all of these. And if you were to label this is something probably similar to what you would come up with. We have a new step to label. That is this area right here. The difference between plateau and PEEP is what we call driving pressure. Okay, so that's a delta P. That's driving pressure. Okay, perfect. We got it, right? Everybody knows what driving pressure is, right? No, of course not. We may know where to label it. We may know where we can find it on the pressure waveform. We still don't know what it is. So let's take this a step further. Let's say that driving pressure, and I'm just gonna illustrate this with like I said, the delta P right here. Okay, so we know that delta P equals plateau minus PEEP. Okay, so that explains it, right? That tells us what driving pressure is. Still not. I can't tell you how many messages I get that say, what is driving pressure? And they say, don't tell me the formula. I need to know what it is, because while this is the formula, it still doesn't help us define what driving pressure is. And so a lot of times I say, okay, well, have we seen this before? And the answer is yes, we have. So where have we seen that before? Well, if we remember, our static compliance formula says that tidal volume divided by plateau minus PEEP. That's where we've seen it before. Okay, so it would be fair to say that static compliance is actually tidal volume divided by driving pressure. Perfect. So we're getting closer, right? We're getting closer to really seeing and understanding what driving pressure is. Now, if we go back to our algebra days, we know that we can move this formula around, and we can take delta P from off of the bottom and we can put it over here on this side. So if we multiply both sides by delta P, we'll see that delta P times static compliance equals tidal volume. Now this is going to be important, because where we're going, this is a key element, okay? Because we just found a new formula to help us determine tidal volume. Now, still haven't got the definition of driving pressure. So we just make one more move here, and we divide both of these sides by static compliance, and that'll get us driving pressure by itself. And what we're left with is this: driving pressure equals tidal volume divided by static compliance. Now that's a formula that we can work with and develop a definition off of. Because what this says is that driving pressure is the ratio of tidal volume to static compliance. In other words, is your tidal volume appropriate in relationship to what your compliance level is? And we know that's changing constantly. We have disease processes, compliance improves, it gets worse, and constantly it's changing, which if we're utilizing a set tidal volume, then you can see what's going to happen is our delta P is going to change. If tidal volume is constant, compliance is changing, then delta P has to change. Now, the interesting thing about this is that if we can control delta P, then these have to become variable. We already know static compliance is variable. So the question is right here, are we setting tidal volume appropriate to our static compliance? And that's the definition of driving pressure, the ratio of tidal volume to alveolar static compliance. So we have a definition, and we can work with that. Now, where are we going with this, right? Now, what do you mean out with the old, in with the new? Well, let's go back just a little bit here. We won't stay here too long, and I know you can't read this, but you should recognize this. This is the ARDSNet protocol. And the reason I bring this up is because I want to point out some things. Remember when this protocol came out, it was early 2000s, and this protocol showed up and it completely shifted everything, which I kind of touched on earlier. It took our minds from large tidal volumes and low peeps to a different mindset and a different practice that slowly took root and is now basically what we do every single day in the ICUs. Now, what we see here is that the first thing it did was it put an emphasis on changing the size of the tidal volume. So you were going to start at 8 mLs per kilogram and then move down to 6. And 6 was going to be your big goal. Okay, so basically the shift to 6 to 8 mLs per kilogram in regards to tidal volume. So the first thing it did, you want to remember tidal volume. It reduced them drastically. Okay, now the next thing it did was it put this emphasis on PEEP. And I don't know about you, but this PEEP table, as stated, never really made a whole lot of sense to me. But we do know that we essentially evolved into where we sought out higher PEEPs with lower FiO2s. So that was the second point that it illustrated. It talked about tidal volume, and then it talked about these PEEP tables over here. And then the third thing, the third point of emphasis that really took hold out of this research and this practice that came to be is the focus right here of keeping plateau pressure less than 30. So this section right here talks about the plateau pressure and where you want that plateau pressure to be, and that's less than 30. Now, nothing about driving pressure. This, when it came out, there was nothing about driving pressure in this original work here, in this original protocol. It was tidal volume, it was PEEP, and it was plateau. Those were the areas of focus. So the authors of this study, after it was published, they came back 15 years later in 2015, and they basically looked at a very large sample of patients that had been on and used and implemented the ARSNet protocol on. And what they did was they did basically a big meta-analysis. It was all, I think it was somewhere over like 3,500 different patients that they looked at. And what they said was, I think this is a genius move, because they said, okay, let's see if what we said this was going to do, let's see if it actually did it. And then also, let's see if there's something else to this. Here's what they did. They looked at all of those patients and they started grouping them in groups. So you can see here, they took 1, 2, 3, 4, 5 different groups of patients, all out of that sample size. And they said, you know what we're going to do? We're going to match them to a PEEP level. And so they put 5 different groups, but all the groups had the same set PEEP. And what they looked at was, let's see what the impact was on plateau pressure. And you can see that with 1, 2, 3, 4, 5 different groups here, you ended up with varying plateau pressures. Now, if you remember, driving pressure is the difference from plateau to PEEP. And so obviously this patient sample here has a larger driving pressure than this sample here. And then they put that and they said, what effect did this have on mortality? Beautiful thing here. Look what happened. Not the mortality part, but look at the way this works. As this goes, this end right here matches up to this sample over here. So you can see as driving pressure, well, in their mind, as plateau pressure was rising against a standard PEEP, they identified an increasing driving pressure and mortality rose linear with it. So in other words, the higher the driving pressure was, the higher the mortality risk was. Now, when we look here, the next one they did was they took another sample. And this time they reshuffled them and they put them all back in. They had 5 different groups here. This time they compared standardizing plateau pressure. So you can see here now our plateau pressure is constant. And they said, okay, well, what happens when we mix up all of these different plateau pressure, all this standard plateau pressure? What happens when we mix up all the different PEEP levels that were used in that? And you can see we start here with a very low PEEP level and the PEEP level rises. So this one is the exact opposite of what the previous image we were looking at was. because on the previous image, driving pressure got larger as plateau pressure went up. But here we see as we increase PEEP with a standard plateau, that driving pressure actually goes down. Driving pressure here is much larger than driving pressure here. Look what happens, the exact opposite. So what did this support? This supported the same thing they found in the previous slide, in the previous image. They said, okay, obviously there's something here with this driving pressure, because as driving pressure increases, mortality increases. As driving pressure decreases, mortality decreases. Perfect. They shuffled these up one more time. And this time they rearranged them into a group where driving pressure was constant amongst the 5 different groups. And not shocking, look what we found. A standardization of mortality. This is important because a study that came out with the focus on tidal volume, PEEP, and plateau pressure, never mentioning driving pressure, is able to come back and go, wait a second. The kicker, the big player in this game is really nothing that we set out to control. What it is driving pressure, the difference between plateau and PEEP. And this is the image right here that supported that mind-opening moment that I had. Now you put all these together and you can see it here the way they present it in their presentation. What this tells us is this one over here was the stabilized PEEP. When you compare it to the driving pressure range, you can see is that PEEP alone is not the factor. When you compare it to the standardized plateau pressures, then you can see it to where it's not the only driving force. What was the single driving force to equalize mortality was the driving pressure sample. And so they state down here, higher plateau pressures, not always risky. In contrast to that, higher PEEP levels were not always protective. And so it's interesting how that they found this and identified this in relationship to mortality. Now, the question is it feasible for driving pressure to be a primary driver? Get that pun there, right? Driver in the management of mechanical ventilation. And what do I mean by that? What I'm asking here is what I'm diving into here is the research that is happening right now that is looking at it going, you know, how many times do we get a patient? We set them on a mechanical ventilator. We set their tidal volume at 6 mLs per kilogram. And what we find is that tidal volume stays at 6 mLs per kilogram for the duration of that course of mechanical ventilation. What this poses to ask is what if there was a style of mechanical ventilation management where the optimizing of PEEP in conjunction with a fluid movement of tidal volume on a routine basis, all surrounding this idea of standardizing and minimizing a driving pressure. Is that possible? Is it possible, and is it the future? Now, a big concern with this is well, if you start messing with tidal volume too much, you're going to start messing with ventilation, right? We all know this. So how low are you talking about potentially going on tidal volume? Well, study here done by Romano and colleagues, they did a study, and their whole purpose of the study was to answer this question. Is it feasible to be done like this? And if so, is there a risk of respiratory acidosis when you start dropping down to much lower tidal volumes? So we know right now the ARSNet protocol tells us that we can go as low as 4. Well, this study went as low as 3 mLs per kilogram. And what they found was, yes, there was a small level of rising in CO2, but not a severe acidosis and not enough to say that it's not feasible. And so, of course, you're going to have to use higher rates when you start getting down to those lower tidal volumes. But this study was a randomized controlled trial. This study supported and showed that while that's a concern, it's not a prevalent concern. It's something you have to be aware of, but the feasibility of optimizing and using driving pressure as the main mechanism for decision making when it comes to mechanical ventilation is feasible. I thought that was interesting. So there's a lot of research going on in this. If you just go to your database and just start driving pressure, you'll find an ample amount of research over this. Currently, what's happening right now with the driving pressure and what most studies are doing is they're validating this. Is there a reduction in mortality and the risk for pulmonary complications with a smaller driving pressure and lower driving pressures? The methodology is where we're getting lost in, and we still haven't found the exact best way to do it, but this is what we're finding. A lot of studies go out there and say, you know what we're going to do? We're going to set a PEEP level, and then we're going to adjust the tidal volume to get us to that driving pressure. So let's say you set a PEEP of 10. So PEEP goes to 10. And let's say you have a tidal volume set at 6 mLs per kilogram, and that yields a plateau pressure of let's say 30. Well, you can see here where the difference, 30 minus 10, gives us a delta P of 20. Well, that's too high, because what we know is that driving pressures less than 12 to 13 are where we want to be. Okay, so we're looking for driving pressures 10, 11, 12. You start getting 13, 14, 15, that's where those risks for pulmonary complications and mortality start showing back up. So in this case, you have a delta P of 20. They would come in and they would reduce the tidal volume to 5 mLs per kilogram. And you would say, okay, well, what's our plateau pressure now? Because obviously, whatever tidal volume you put on top of a set PEEP is going to lead to a plateau pressure. So they drop it to 5, the plateau pressure comes down. If it's still above that mark that they set, then they drop the tidal volume even further. And they keep dropping the tidal volume until they get that plateau pressure less than 13 to 15 centimeters of water pressure. And that's what they did. Now, the problem with this is, and as we know, every study has limitations. And so it's fair to talk about the limitations. The problem with this is that we know that PEEP directly impacts compliance. You remember, this was part of the compliance formula. You remember, static compliance equals tidal volume over plateau minus PEEP. Well, there's PEEP. PEEP is a part of the static compliance formula. We know that compliance is going to affect plateau. So, how effective are we figuring out, with the set PEEP, does it really evaluate the true potential without optimizing PEEP? And that was the question. They also showed on these studies that you did low level PEEP versus higher level PEEP. The higher level PEEP with the set tidal volume, this is important, right? With the adjusting tidal volume, the higher PEEPs had a higher risk of pulmonary complications. So essentially they were able to pull out of that, well, yes, you can shoot, you can target for a driving pressure while adjusting tidal volume, but if you're not truly optimizing PEEP, then going with extremely high PEEPs doesn't always lead to better outcomes. We already saw that with the ARTSNet protocol. So this group right here, this is Romano, Park, and Deontay and their colleagues. These are, I have references at the end that I'll provide you. Looked at adjusting tidal volume with a set PEEP. Now, there's another group, another research happening out there where we are adjusting PEEP while using a constant tidal volume. Okay, so here, the goal to get the delta P, the driving pressure, to that minimum state did not revolve around changing tidal volume. Tidal volume was set 6 mLs per kilogram, and it did not move. All we did here was adjust the PEEP. So in this case, you see where now we're not optimizing tidal volume in regards to optimal PEEP setting. Now we can be in a place to where maybe our PEEP settings are too low or too high, depending on driving pressure, but it still doesn't bring the two together. And I think that's where this goes, because it really is a conjunction of both of these together. I like this image right here. I think it does a good job of illustrating how and what we're talking about. So if you look up here at this first one here, this is A. If you look right here, this illustrates a lung, and this says end expiration. So this open area right here is basically a representation of PEEP. Now you can see here that at the end of expiration, just prior to inspiration, we're not fully recruited. So this lung, you could say, is underinflated to begin with. There is not good equal homogeneous alveolar gas distribution. And so when you put that tidal volume on top of this under aerated lung, then what you see is you get overexpansion of essentially just the good lung. And that leads to an increase in plateau, an increase in delta P, and overall an increase in your stress index, which we know is not good. You get release of cytokines and different inflammatory mediators anytime we overstretch lungs. So this is what this one right here, this kind of reminds me of the IPPB argument, where it's like, oh, IPPB is not very effective in recruiting. It just proved to hyperinflate what the healthy lung is already open to. And so that's kind of what I equate this one to. Now, the second one here is kind of the same thing. It kind of shows the same thing. You start with an underinflated lung, so PEEP level is not maximized. You put a tidal volume on top of that, and even though you get better aeration here than what we did up here, because we started so low, you still get this increased plateau, this increased driving pressure, and an increased stress index because we started so low. You still get better aeration with the tidal volume, but it doesn't optimize the entire process. And I think that is extremely important to recognize here. When we get here, we see that we have a PEEP level, that our alveoli are being held open to a pretty good area here. This is pretty good open lung concept. The lung is at a resting state during expiration, to where when the tidal volume is applied, you see equal and good expansion of the lungs, homogeneous gas distribution, and this minimizes the driving pressure, minimizes the stress index, and ultimately is what we are shooting for is right here. The last one here, D, shows basically where you are starting at an area of hyperinflation. So this is where, when you have that PEEP setting that is set too high and you're overinflated, you're at a resting state that is too much. And so you can see from right here, you're already overstretching the lungs at the expiratory phase just with your PEEP setting. So then obviously when you put a tidal volume on top of that, all it's going to do is just further stretch, because we started at an overinflated point. And so you see your delta P, your driving pressure goes back up to 20, and your stress index rises back up above 1. Not good, not going to promote healthy lung function, reduce pulmonary complications. It's just not going to happen. So again, what this illustration does for us is just kind of brings it all back home and shows and talks about, when you think about PEEP and tidal volume, you have to recognize that they have to be blended and meshed together very, very intentionally. We can go too little PEEP and still get overexpansion of our lungs, even when we're using an appropriate size tidal volume. We can go over the top on the PEEP, and we put our lungs at a state of overexpansion to start with, and then you can put an appropriate size tidal volume on top of that, and you still are going to lead to overinflation, increased pulmonary complications, increased mortality, increased stress index. So what we're looking for here is if driving pressure can be the focus, if driving pressure is the tool to show us when we are achieving this, then I think it's worth looking into and evaluating and trying to get to a state to where maybe that's where we should be going. Now, let's go back to this question right here. Which patient has a higher risk for mortality? Now, at this point, if I've done my job, then you know the answer, right? You know that you can look over here at patient A and you see a tidal volume, 6 mLs per kilogram. You're not worried about that. What you are looking at is the difference between plateau and peak. So here, 28 minus 8 equals 20. This is our driving pressure. When we look over here at patient B, we look at the difference between plateau and peak, and we see a driving pressure of 12. This patient has a lower risk. Patient A is the patient with the higher risk for mortality based off of driving pressure. Now, I'm not talking about other mortalities that might be coming along with this, okay? We know that there are various things that affect mortality. But just from the driving pressure conversation, we see here that this PEEP of 20 resulting in this plateau of 32 actually is a better indicator than this PEEP of 8 with a plateau that is less than 30. So you think, oh, that plateau is less than 30, we're doing great. Where in actuality, we're not doing so hot at all because our driving pressure is still elevated. Okay, now when we talk about assessing driving pressure, we know that this is all based off of essentially the assessment of plateau pressure and the assessment of PEEP. And so as you assess your driving pressure, it is going to revolve around a plateau pressure. So this is going to be one element of it, right? Now, we know, and we've probably all seen, if I was to draw this like this, where we get like this, and we get something like that on our inspiratory hold. This is an indication of an actively breathing patient during that inspiratory hold. So this makes it complicated to get an accurate plateau pressure because of that active diaphragm. So you as the respiratory therapist, you know this, you're going to pick up on this. You're going to say, hey, plateau pressure, what if it read up here? What if it gave you this reading right here? Well, that's obviously not right because the diaphragm is coming back up, right? What if you look at it and go, it must be that value right there? Well, that's not right because here the diaphragm is sucking in, right? So we know that the plateau pressure is in this area right here, but that may not be the number that your mechanical ventilator provides you when you do this assessment. And so being on the lookout and just aware that active diaphragms during an inspiratory hold will alter your plateau pressure. And this is no different than what we've been doing forever. You've been assessing plateau pressures to look at static compliance, hopefully for a long time. And this same conversation can apply to that as well. But now that we're looking at driving pressure, knowing that we're going to be taking our plateau pressure and subtracting our PEEP, it's extremely important to have that accurate plateau pressure. Now, the second thing that will alter your driving pressure number that you get is the presence of auto PEEP. So when you look at this and you take our waveform here again like this, and we've got our patient that comes up here, we get a good plateau pressure. But let's say our PEEP level is set here. But we're not coming back to our PEEP level because we have the presence of air trapping leading to auto PEEP. The important thing to note is that when you are calculating driving pressure, you are going to take plateau and you are going to subtract total PEEP. It's not the set PEEP. And so the assessment of auto PEEP is very, very important. So let's say you have a plateau pressure of 20 and you're on a set PEEP of, let's just say 8. but you have a total PEEP or an auto PEEP up here at 12, well, your driving pressure here is actually 8. So in the numbers game, and where you're minimizing driving pressure, what's going to happen is you may make a decision over here that leads you to doing something because you think your driving pressure may be high. Now, these numbers don't work out because I did 20 and 8, which would give us 12 also. But what if it was 28? Well, now you may be going, oh my gosh, my driving pressure is really, really high. It's 20, where when you take into account the auto PEEP, it's not really 20. It may still not be good, but it's not 20. So the point is to recognize that auto PEEP will blur these lines, and you want to utilize total PEEP. So not your set PEEP when you are looking at and evaluating your driving pressure, and then avoid the active diaphragm. All of these studies, when they break down how they do these things, all of these studies talked about using sometimes even paralyzing agents to eliminate any dyssynchrony during the assessment of that plateau pressure. And you look at research in general, a lot of times it says that that's a favorable action. Maybe you don't need paralyzing agents, but just the use of some type of sedative to eliminate that spontaneous effort or that active diaphragm, so that you can better evaluate true plateau pressure for a better assessment of your driving pressure. Okay, we still got a few more minutes here. I'm going to start wrapping this up. First of all, in summary, this is not a debate. Okay, so the effects of driving pressure are well researched and well documented. The higher your driving pressure, then the greater the risk of mortality and the greater the risk of pulmonary complications. Now, there are populations out there that this does not apply to. So, for example, your obese population, they start off with a reduced chest wall compliance. Research into that population actually revealed that there was not an association with driving pressure and complications of mortality. So there's always going to be outlying populations, which I think is important to know, because when you're taking care of that patient, you may address that patient from a different standpoint. But overall, in the large majority of populations, reduced driving pressure equals reduced pulmonary complications, mortality, better benefits for our patients. Second thing I want to leave you with as we start to wrap this up is mechanical ventilation is more than peak, tidal volume, and plateau. We've kind of been talking about this throughout all of this, but I just want to bring it back and get you to a state of summary here, to where you recognize that I think gone are the days to where we just set a tidal volume, document a plateau pressure, and then change PEEP for what? Because our patients become hypoxemic. The worse the hypoxemia is, the higher the PEEP goes. I would venture to guess that I could probably walk through majority of ICUs, and if I saw somebody on a PEEP of say 17 or 18, most likely that patient's got a terrible PF ratio and they're severely hypoxemic. We've seen this throughout the last year battling COVID. These patients on these very high PEEPs. Why are they on these high PEEPs? Because they're so severely hypoxemic. What we have to remember and remind ourselves is that PEEP is a player in the game of establishing early on an effective compliance. Alveolar static compliance. PEEP plays a big role in that. We talked about that when we looked at the images. Too little PEEP, and you're starting at a state of underinflation. Too much PEEP, and we're starting at a state of overinflation. And so it's very important to recognize that mechanical ventilation, especially when you're talking about driving pressure, takes all of these and puts them into one beautiful mesh. And each part tidal volume, PEEP, have to play equal parts. Both of them are valuable, and both of them have to be at least considered to be varied and changed throughout the mechanical ventilation process for the sake of optimizing driving pressure, or maybe I should say minimize driving pressure. And so I think that's a key point that I want to leave you with. And then I have 3 questions for you, just kind of open up a discussion here, if you will. The first question is, are you assessing driving pressure? So, is this something that you routinely do every time you stand in front of one of your mechanically ventilated patients? Are you asking yourself, what is my driving pressure? If you are asking yourself that, my next question is are we documenting it in the EMR? Is there a place in your EMR where driving pressure is documented? For years now, we've had the flow sheets, tidal volume, exhale tidal volume, rate, set rate, total rate, spontaneous rate, minute ventilation. Go down the list, right? We can probably list them off like that, right? Where's driving pressure in that list? I haven't seen one yet, and I'm curious if you are seeing it on your EMR yet. The reason this is important is because imagine the shift in mindset that it's going to require for us to be ready and open and willing to change our mindset when it comes to mechanical ventilation to operating off of a set driving pressure rather than a set tidal volume. And yes, all the research says more research is needed to really find the right blending and how do we optimize PEEP and how do we optimize tidal volume to optimize driving pressure. Yeah, that's true. But imagine when it happens and the next ARSNet protocol comes out and it's based off of a set driving pressure. I remember the obstacles and the hurdles to have to adjust my mind from 10 mLs per kilogram to 6 mLs per kilogram. And I remember the resistance that came with it. So how's the resistance going to look for that change of thought process? I think the first step to getting us to even being more open to this idea is starting to talk about it and starting to document it so that it becomes a routine assessment rather than something coming at us out of left field. And then the third question I have is if you're not documenting it currently, if this is something that you currently don't even assess, I'm just going to ask if you'll consider it the next time you step in front of your patient's room. Just start considering it and open your mind just a little bit to the value that driving pressure can bring to you as a clinician and upping your game and show your value to the healthcare team. During rounds, you want to talk about driving pressure and what will you get out of that from perception from others. And then ultimately for the betterment of our patients. If you can point to one thing and say, hey, this shows a reduction in pulmonary complications and mortality, then why would we not even be considering it and assessing it routinely for the betterment of our patients? Okay, so that's what I want to leave you with.
Okay, we've got a couple of questions here. How long were patients on mechanical ventilation? Do these insights apply to short-term patients?
The studies kind of vary. Some of them are very short, just a couple of days. There were some studies that went out as long as 10 days. What a lot of the studies show was that the optimizing of driving pressure in the first hour of mechanical ventilation actually showed very promising effects for however many days were to follow.
Wondering, can you cover calculating driving pressure when using APRV? Is there a consensus on how to measure it?
There's not. And here's the problem with APRV. When you look at the research and the data on it, what it says is that while you can use that PEEP high as an indicator, what is extremely and almost impossible to measure is the end PEEP, the PEEP low, because most of the time what you're utilizing is an air trapping technique. And there's not a consensus, even if you can measure that PEEP low, that it's an accurate reflection of actual end expiratory pressure. It does indicate end expiratory pressure. What it doesn't tell us is what we know is that in non-compliant areas of the lungs, they empty much quicker than healthy elements of the lungs. And so when you look at that PEEP load, the question is, there's a lack of homogeneous alveolar gas distribution. So it's not the same as with a PEEP setting where it sits there. It's funny that question comes up again, Keith, because we talked about this during the APRV conversation, to where calculating driving pressure in APRV, at least to date, and what everything states is that there's not a reliable method to do so.